61st session of Pediatric Orthopedic Advanced Learning Session. It's my privilege to introduce today's esteemed speaker, Professor Vincent Mosca. He is Emeritus Professor at Seattle Children's Hospital. He is a leading authority on the subject, and his book, now in the second edition, is The Authentic Resources of Pediatric Foot Problems. In previous sessions, we have discussed common pediatric conditions like flat foot, rigid foot, cavus foot, the management of the neuromuscular foot. Today, we are going to discuss a not so common conditions in pediatric foot. And we will discuss the management of Sever's disease, accessory navicular bone, and Collar's disease. The session is very different than the conventional lecture. It's not a didactic lecture, but it's going to be an interactive session. And the aim of that session is to stimulate the thinking of our young pediatric orthopedic surgeons. We will try to explore the questions which come in our mind when we are interacting with the patient. Those questions we will discuss in today's session, and some of the questions which are asked by parents. So this is what the session is. And before I hand over to Professor Hitesh for the case discussion, I would like to express my gratitude to OrthoTV for its unwavering support to this academic initiative, which aim at to mentor and groom the young pediatric orthopedic surgeons, not only in India, but worldwide. So with that, I request Hitesh to take over.
Yeah. Good evening, friends. Dhiren bhai, thank you for that. Dhiren bhai, whether screen is visible, is
yes.
Full screen? Yeah, okay.
Yes, yeah, it's full screen.
Yeah. Thank you actually very much. We have already discussed the few sessions. We are lucky enough to have Dr. Mosca sir with us for the pediatric foot session. We have discussed the flat feet and all other aspect what Dhiren bhai has already said, but we have not discussed the common foot problem, which is common as well as uncommon. Not common for the surgical intervention, but that will be presented to the clinic, very, very common. So without wasting the time, we'll go the first case. That's a 10-year-old boy present with a bilateral heel pain, and the tenderness was present at the heel, and these were the X-rays. So the diagnosis, most of us will do the diagnosis as the serious disease, but that's common question to the parents and the physician and ortho and pediatric orthopedic surgeon. What are the diagnostic tool for the Sever's disease? We'll ask the Mosca sir.
Well, thank you once again for inviting me to participate. These sessions have been wonderful. I lost count now, but I know I've participated in several of them, and it's just been great to interact. I teach, I learn. Questions are so important in sessions like this, because we who have been doing this career for many, actually decades, have certain knowledge and experience that we just sort of take things for granted. So when we're talking about the big topics like flat foot, cavus, club foot, we sort of know how to hit all the high points. But now we're talking about heel pain in young children. And although many of us who have had decades of experience don't spend a lot of our time focusing or even thinking about these anymore, because it's just so obvious what it isn't that obvious, especially for juniors. So to discuss it really brings us back to basics, that we are orthopedic surgeons, and in our cases, some of us, like Darren and Hitesh and Thomas, we're pediatric orthopedic surgeons. But the surgeon part could also be replaced with that we're pediatric orthopedists. Not orthopedic surgeons, but orthopedists, meaning that we manage the musculoskeletal system in children and its conditions and afflictions. And that unlike cardiac surgeons and unlike neurosurgeons, the goal of our clinical practices is not to operate on children. The goal of our practice is to relieve pain and disability created by problems in the child's musculoskeletal systems. I just want to say that again. We are not practitioners who want or need to operate. We know how to, we enjoy operating, but our goal, what we're charged with in our profession, is to manage pain and disability created by problems in the musculoskeletal system of children. And that always starts non-operatively. And if the non-operative treatment doesn't relieve pain or restore function, then there's a role for surgery. So we know where the clinic is. We spend time in the clinic, unlike neurosurgeons and cardiac surgeons who only know where the operating room is. So let's come back then with that as a foundation to say, what do you see here? Well, these are nicely positioned lateral x-rays of feet in a young child. We know the child is 10 based on the growth plates. That makes sense. And we know that these are true lateral x-rays because the back shadow, the posterior shadow of the fibula is collinear with the posterior shadow of the tibial epiphysis. That defines a true lateral, not the shape of the dome of the talus. Is the posterior cortex of the fibula and that of the tibia, are they collinear? And the answer is yes, plus or minus 2 millimeters. So these are true laterals. Looking around, we don't see anything else except the apophysis, the growth plate on the posterior aspect of the calcaneus looks irregular, not symmetric and not regular. There's not a homogeneous pattern. If you look at the right foot, you see sclerosis that's a little bit more calcium intense than the main body of the calcaneus, and that the physis between the calcified apophysis and the main body of the calcaneus is irregular, and that there are sort of circles and O's in the apophyseal calcification center. And if we look at the left foot, which is on the right side of the screen, it looks like at least 2 major ossification centers in the ossified apophysis. One of them is long and thin and very sclerotic, very white, and the other is not as white, more homogeneous, more of a gray color. So they're not symmetric. It's the same child. Is this a disease? And the answer is no. This is the way the apophysis takes on calcium in young children. At birth, there's ossification of the talus, a single ossification of the calcaneus, often of the cuboid, and all the metatarsals are ossified. But there's not much other ossification in foot bones in newborns. And as children grow, even in the first several years, months and years, calcium is deposited in the center of ossification and then in the secondary centers in a predicted pattern. It's not always consistent. It's not always the same. As for the apophysis of the calcaneus, it always comes in irregularly. Now, if you think about other apophyses or epiphyses, like the distal fibula epiphysis, it almost always comes in as a single ossification center that enlarges and enlarges. But for the calcaneal apophysis, it comes in irregularly. It looks fragmented. It looks avascular. It just looks like a disease. And what you need to know is that it's not a disease. But can it be a disease? And that's the question, because X-rays don't make diagnoses. Physicians make diagnoses based on history, physical, and in this case, imaging findings. So if this is not Sever, well, so what says it could be Sever's? Boys more commonly than girls have heel pain due to Sever's calcaneal apophysitis. The child is 10 years old. That also fits. Sever's is typically experienced or identified in the first 10 to 11 years of life. So we've got the right gender and we have the right age, and we have x-rays that look like they look. So this is Sever's, right? Could it be anything else? The child has heel pain. So can we move on to the next x-ray? Oh, next slide. So this is, oh, that's good. Go back to that one, please. So here we're looking at the
Now, Hitesh, back one.
the previous one, the Harris view. Yeah, so there's a Harris view. And again, what you can see is the ossification of the apophysis is somewhat irregular. There's one vertical dark striation in it. And if you look at the apophyseal cartilage, it almost looks like there's a cyst. It almost looks like there's a space-occupying lesion that has eliminated, just a little higher right there. So more like in the middle. It looked right there. It looks like something happened there. So you're thinking, okay, I know Sever's is supposed to be an apophyseal problem, but that looks like there's some loss of calcium in the main body of the calcaneus adjacent to the apophysis. So let's move on to the next slide now.
Now, before that, I have a question. Then, how can we diagnose severs on X-ray? So what you said is on the clinical ground, but how X-ray helps us in diagnosis?
We can't.
Okay.
We can't. It's it would be a false jump to a conclusion on something that always looks like it's diseased. The apophysis of the calcaneus always looks like it's diseased, and it almost never is, unless you consider Sever's a disease, and I don't. It's a temporary growth abnormality. So you cannot make the diagnosis on X-ray. In fact, one of the real questions is whether you should even get X-rays, but we'll come back to that. So let's move on.
Yeah, that was my question. Should we get the X-ray? And if it is yes, what are the views and when?
Yeah. Okay. So let's go on and we'll come back to if X-rays are necessary.
Yeah.
So I think of heel pain, and Sever's is one of the reasons for heel pain in young children. There are several ways that you can assess this with your index finger or with your index and your thumb. Achilles tendonitis can happen. It's not common in the first decade of life, but it can happen. It can be an overuse syndrome. And Achilles tendonitis, next, is when you palpate from posterior to anterior, from back to front, over the last few centimeters of the tendon Achilles. If the tendon Achilles has an inflammation from overuse, it's generally tender along the bare part of the tendon as it approaches the calcaneus, not where the muscle is. It's a tendonitis. So if you just put your finger in right where that green arrow is, and that's the point of maximum tenderness, PMI, point of maximum tenderness, it's likely that's the Achilles tendonitis. Next. Just anterior to the insertion of the tendon Achilles on the calcaneus is a bursa. And it's not going to be tender unless it's inflamed. But just as one can overdo and inflame the tendon Achilles, one can inflame the bursa anterior to the insertion of the tendon Achilles. So if the palpation is 2 centimeters or so above the insertion on the calcaneus, then it's a tendon Achilles tendonitis. But if the tenderness is right at the insertion in a child, it's either that or erythrocalcaneal bursitis. Again, it's an inflammation, and by palpating from posterior to anterior, if that's the point of maximal tenderness, that's probably it. And some kids also have, and adults, have a bony enlargement of the calcaneus at that site. We call it Haglund's deformity, and that can also be a site of either insertional inflammation or because that bump of bone on the back of the calcaneus is large, it pushes the skin into the shoe counter, and one can have pain at that location because of skin compression, skin sandwiching between the shoe and Haglund's bony prominence. So there can be skin pain right there. But you'll know that by taking your index finger and just pointing right on that and say, yeah, this is skin deep. So this is Haglund's. And we need to modify the shoes so that there's no more sandwiching of the skin in that area. Next. The x-rays that were obtained suggested Sever's apophysitis. Sever was the person who described it. The apophysis, as you know, is an epiphysis that doesn't end in a joint. That's the difference between apophysis, it's upon the physis, and an epiphysis, which is epi next to the metaphysis. So both the apophysis and epiphysis have growth plate cartilage. An epiphysis has a bone and epiphysis on the other side of the joint, and apophysis does not have a bone or joint on the other side of it. But otherwise, they have the same sort of clinical features. They have a growth plate that enlarges the bone. They have the end of the bone that is covered for protection, either in this case, protection against contact with the ground, or at a joint, contact with the other bone at the joint. There are a lot of similarities, but they're not identical. So Sever's is not a problem actually within the apophyseal calcium. It's an inflammation of the growth plate, of the apophyseal growth plate, that black line that we're looking at. So if you have a child with Sever's and you push with your finger, if we look at the upper part of that sketch, which I made, I think 15 years ago at least, but if you look at that arrow on the upper part of the sketch, if you push directly from posterior to anterior on a child with Sever's, they will not complain of pain because they're not tender in the apophysis. They're tender in the apophyseal growth plate. So, like the one below, the two arrows towards each other, if you squeeze with your index and thumb side to side on the posterior plantar most part of the calcaneus, that's when they're going to say, oh, that's it. Okay, so this is a distinction. So far we said you push from back to forth for Achilles, retrocalcaneal bursitis, but for Sever's, instead of pushing from posterior to anterior, you squeeze from side to side, a centimeter, half a centimeter in from the most posterior plantar part of the calcaneus, and that's when the child's going to react. They might react if you push the other way, but it's that side-to-side squeeze that is going to say, yeah, that's what hurts them the most. You know that you're squeezing the apophyseal growth plate cartilage, and that confirms your diagnosis. Next. So, what can be confused with that side-to-side squeeze? Well, some kids, even young kids, look at that x-ray on the bottom. You can see the sclerosis. That's a calcaneal body stress fracture. And it's in partial state of healing because there's sclerosis. You don't see any blackness in there. It's actually increased calcium. So that's a stress fracture of the calcaneus. And that is also diagnosed by a side-to-side squeeze with your thumb and your index finger. It just isn't at the most posterior part of the calcaneus. It's about 1 to 1.5, maybe 2 centimeters more anterior. So very, very, very close. But again, that a stress fracture like Sever's is not going to be identified clinically by a single finger. It's got to be the side to side. And the question is it more anterior or more posterior that the side to side squeezing is causing the maximum discomfort for the child? Next. And then, kids jump off things. They jump off high things and they land on their feet. And unlike adults who jump off high things and break things, kids can get what we call either a heel bruise or a stone bruise, or some adults who have plantar fasciitis with insertional inflammation. But when kids jump down really, really hard with or without their shoes, they can just develop a bruise where the plantar aspect of the calcaneus tuber gets squeezed against the plantar skin. So that's one too, where if you push with your index finger from plantar to dorsal, and that's the point of maximum tenderness, don't start thinking about plantar fasciitis, something you diagnose in a 50-year-old woman. This is, they jumped and they have a heel bruise. Again, it's a single finger diagnosis from under to up. Next. So those are the finger, we'll call those the finger diagnoses. And then there are other possibilities. Osteomyelitis, as I said, in that initial x-ray that his test showed, there looked like there was some loss of calcium. That when we know about growth plate infections at other sites, look like loss of calcium in that pattern. So that x-ray could have suggested infection. The thing you need to know about the calcaneal apophysis is that it is almost never the site of hematogenous osteomyelitis. It just doesn't happen. There are so many other better growth plates that bacteria can stop in children. They just don't want to stop at the heel. So how might you get, and I've had one child who had osteo at that location. It was a direct puncture wound. So look for puncture wounds. And if you see a puncture wound, if there's inflammation, redness, certainly drainage, then osteomyelitis should be in your differential diagnosis. But you have to, for there to be infection there, it had to get there from the outside, not from the bloodstream. So when you're evaluating the child, the first thing you're going to see before you even touch them is a red, swollen, hot heel. Then you start going down the path of, is this osteomyelitis? Another reason for your heel pain could be an osteoid osteoma. And you know what those look like. It's the sclerotic hole. It's not going to be at the physis. It's going to be further in the body of the calcaneus. Just as a unicameral bone cyst, which happens in calcaneus, is typically just under the central portion of the calcaneus, not in the back, and should not be confused. And typically UCBs don't hurt with palpation, they hurt, and then you get the x-ray and you see the large lytic, well-outlined, well-circumscribed hole created by the UBC. And then certainly heel pain can be due to soft tissue foreign body, with or without osteomyelitis, and those are things that you look for in entry wound. You look for inflammation, other things that could say that's the reason for heel pain. So this is a rough way of looking at things using the finger test, which single finger for all those colorful diagnoses on top, except for Sever's, and stress fracture, which is side to side, either more posterior for Sever's or slightly more anterior for stress fracture. So then the question is, child comes in, 10 years old, 8 years old, active kid running all over the place, and has heel pain. Hasn't slowed him down. He's still running all over the place. He's just complaining of heel pain. And the parents finally couldn't take it anymore, and they brought him in to see you. So you do your exam, and you say, based on my clinical evaluation, I believe this is Sever's. X-rays, I think it's appropriate to get X-rays. They're generally not very expensive. Even in the US. I mean, everything's expensive in the US, but x-rays are about as inexpensive as you can get. And then you get the x-rays. Be prepared that when the parents see the x-rays, they're going to go crazy. They're just going to freak out when they see what we just talked about, which is normal. So your choice is to either have your script in your mind, what you're going to say, and or keep some pictures of x-rays of Sever's in your office in a folder where when you're showing them the x-rays, you can also take out your book, either textbook or examples of others of your patients, and say, see, this looks just like this, or they both look weird, they're both normal. Because they're going to need to have some more confidence than no matter how well respected you are in your community to believe that what looks abnormal to any reasonable person is okay. So I would say that's what you would, one way to just get the visit over with more quickly and give the child and family what they need, which is education. Next slide.
Yep.
So there again is another example of that. If that came up and the family's in the room, they're going to say, that's a disease. Either you tell me how we're going to operate on this, or I'm going to go see somebody else. That's why you need other examples. And then I showed on the right side, that's an abnormal bone scan. Well, nobody gets bone scans anymore, but some people go automatically to an MRI, both of which are extremely expensive and are going to show what looks like osteosarcoma, right? I mean, look at the intensity of the uptake on that one heel. And if it was an MRI, it would be just on fire, that there'd be so much uptake. So you don't want to get those images, because then it's going to be even harder to explain that it's normal. Plus, it's very expensive. An MRI of a 10-year-old in the US would be at least $2,000, maybe more. And in a younger child who would need sedation, that would add another $2,000 to $3,000 onto it. It's ridiculous for a condition that always gets better on its own. So advanced imaging is rarely, if ever, indicated for heel pain, unless there's something about it that says, maybe I see a puncture wound, maybe this is osteo. Well, the first thing to do is still not go for imaging, but get the CBC, get a SED rate, get C-reactive protein, get other inflammatory markers, which are more diagnostic than an imaging study that's going to show inflammation. You know it's going to show inflammation. That's not diagnostic. What would be diagnostic? If you think that an infection is in the differential, then you get inflammatory markers, CBC, SED rate, and CRP. So you might not even need more imaging after that, but at least you start with what's more specific, which is the blood tests. All right, questions?
Yeah.
Yeah, before we move on, like I just have a query. What is the exact cause of this condition? It's a reduction in the blood supply, or it's a trauma, repeated trauma, because we see particularly the young children who are very active, or it's something else. What is the actual pathology over there?
The answer is that it can be a lot of different things. It isn't extremely well known, but in cases I don't know if there have been biopsies, but there's disorganized and inflamed growth plate cartilage when it's been looked at histologically. Some people believe that there's a tug of war between a slightly tight tendo-Achilles and a tight plantar fascia. So in these very active young boys in particular, who are jumping off things and running, and they never slow down. They don't know how to slow down. That this tug of war between the tendo-Achilles and the plantar fascia, tendo-Achilles, plantar fascia, keep pulling back and forth, putting a shear stress on the physis of the apophysis. And that may lead to that. Because we're going to talk about two other diagnoses that are also likely related to stress. And maybe the comparable to this would be the accessory navicular, this tug of war between the tib post and the foot, going back and forth and putting stress on an accessory navicular. And here's between the tendo-Achilles and the plantar fascia that insert at either end of the apophysis that could be causing some shear repetitive cyclic stress.
Yeah. The question the parents generally ask, how long pain will, what should we do? We should treat them or just do the counseling, just reassurance or treat them? And what is the first line of treatment and what will you do for the recurrence? These are the common question from parents.
So for those parents who have the long vision, which is none of them, because they just want their kids to feel better and stop complaining, once the physis fuses, there can't be inflammation in it anymore. Bone doesn't get inflamed, growth plate cartilage becomes inflamed, but that's not going to be for many years.
Yeah.
This condition generally is painful in between about ages 8 and maybe 11 or 12. It's in that age group. So boys aren't going to fuse their apophysis for several more years, but they're not going to be painful for that long. One of the things I have to tell the parents is that if the child continues to be active and have pain, there's no evidence whatsoever that it's going to lead to permanent pain for the rest of the child's life. The growth plate is going to close. Once it does, there's no way it can be painful. And based on on scientific evidence, this is usually you let it get better. It may come back one more time, but it's rarely a cyclic thing that you treat them non-operatively and then it gets better and it gets worse. If they don't want to slow down, then they're going to have more pain, but they're not going to change the natural history. They're not going to do harm that will affect them later in life. All they're going to have is more pain. So what you can tell the kids is, if you slow down, if you always wear your tennis shoes when you're running rather than going barefoot, if you stop jumping off the roof, if you stop doing these things, your heels will feel better. if you want to continue to do those things, you're going to continue to have pain, but you're not allowed to complain to me.
Okay. Do we ever treat these kids with the plaster for the just rest anytime?
It doesn't affect the healing. It would probably make it feel better if there were extreme pain. So I guess you could offer that as a punishment, but it's not going to affect the natural history of the condition. It would just be a way
Yeah.
of punishing the child.
Yeah. So you
Okay, and
answered the
then
question.
yeah.
Dhiren bhai, yeah, go ahead. No problem.
Yeah, what about the non-operative treatment? The first is like we can suggest non-steroidal anti-inflammatory medicine, a silicone cushion. We can give electrotherapy in the form of ultrasound for the local treatment. So what are the options which you recommend in your practice?
Because everything in the United States is 4
Expensive.
to 40 times expensive, more than it should be. I try to just appeal to reason. I always hated spending healthcare dollars or people's hard-earned money on things that are not necessary. But what you can do is, number one, have the child just the silicone heel, absolutely. A silicone heel cup, which doesn't cost very much, does two things. Number one is that it adds more cushioning. It also elevates the heel. So if this is a tug of war between the tendon of Achilles and the plantar fascia, when you elevate the heel, you suddenly have more laxity in that series between the tendon of Achilles and the plantar fascia. So that takes some of the tension stress off the physis. So a silicone heel cup makes perfect sense. And then the parents just have to say to the kid, listen, you have to not only have to wear your shoes when you're running around, your cushiony gym shoes, but also put the heel cup in. As far as other modalities of decreasing inflammation, again, those all just have dollar signs on them, like ultrasound and involving a physical therapist, which I just don't see any. I certainly don't see any financial value in it. It doesn't change the natural history.
Okay, and like say how long the pain lasts, because many times like after 3 months, 4 months, the parents they go on coming to us that still the child is not better, the child is not better. So what we need to answer them?
You have to say that your child is still not doing what you think they're doing. When you're not watching, they're doing something, because the pain is due to stress. And if it's unstressed, it should feel better. That's just all it is. This is never a surgical disease. I wouldn't even know what surgery could be performed for it. And so maybe that would be the time when you might say, okay, well then we'll put a cast on. And if and that would definitely slow the child down.
Not in this condition, but in other condition, we have tried of like drilling the inflamed area. So do you think that is there any role of any surgical treatment for this condition?
Never.
Never. Okay, right. So no, never. Like say, even if pain lasts for 1 year, still we have to be patient and just say that continue with the same treatment and the pain will disappear.
Yeah, I hate to be dogmatic, but in this case, I would have to be dogmatic and say I've never even heard or read about surgery for this condition.
Okay, right.
Yeah. Did we see any time multicentric the osteochondritis, like the Perthes, the Osgood scatter and Severs together?
So there's a condition called enthesitis.
Yeah.
Enthesitis, enthesitis. And enthesitis is a term applied to inflammation of multiple growth plates or apophyses. It's sort of in the rheumatologic diagnostic category. Multiple inflamed growth plates. And if that's the situation, and so bilateral is two locations, so bilateral Severs, you might say, is enthesitis at two locations. I think if it's at the same level, I wouldn't call it enthesitis, but if you add just one or two other areas of inflammation at growth plates, I would send them to a rheumatologist and let the rheumatologist decide if there's going to be systemic treatment for it.
Okay, there was a question from Akash. So let's take that question. If you have a bilateral pain, especially over the tendo-Achilles insertion, should we suspect inflammatory disorders like enthesitis related to arthritis, or like we need to go for further evaluation for such condition?
So
This is
now,
something like a writer's disease, which we see in adult. Could it be something juvenile version or something like that in this case?
inflammation can always be either focal or systemic. And if it's just in one foot or ankle or both, I wouldn't consider it a systemic disease. But if it expanded beyond that, then I would consider enthesitis. And if an orthopedic surgeon is comfortable treating systemic inflammatory conditions, then I'd say go for it. I always felt that rheumatologists, for a condition I know would never be a surgical condition or one that I felt I knew more about than the rheumatologist, I would treat it. Otherwise, I would refer to the rheumatologist. And then they have, even non-steroidal anti-inflammatories have some side effects. And I don't want to be monitoring their blood tests. I don't want to be doing those things that rheumatologists do for a living. I have other skills. It's not to say that it's below me, but that's what they do well, and they do that all the time.
Yeah, Hitesh, shall we go for the second case?
Yeah, Dhiren, should we go for the second case?
Yeah. Just a slideshow.
This is the first.
No. I will go back. I will take it. Don't worry. I will do 1, 2, 3.
Yeah.
Okay, so this is a second case, and that's on a very condition which we see commonly, not commonly, but also not very rarely. The diagnosis is more or less very clear as soon as we listen to the patient's complaint, that there is a prominence on the medial aspect of the foot, there is a tenderness, and the child is having pain at the site. So these are the pictures which shows that. So now the first question, the diagnosis is more or less very clear. Do you have anything else in mind in this case? Like in the previous condition, you showed a lot of differential diagnoses. So what are the differential diagnoses over in this condition?
So you can see two bony prominences on the medial side of the feet and ankles. One is the medial malleolus, and the other is the other. The other one, the more distal one, can be one of two bones. It can either be the head of the talus or the medial side of an enlarged navicular. How do you tell the difference? So these are non-weight bearing, which means that by default, the subtalar joints have inverted. And if these were flat feet, then they're inverted. It's unlikely then that the bump is the head of the talus. But let me have you all remember the last time you saw a child with flat foot standing. And when someone with a flat foot stands up, there's a bony prominence on the plantar medial aspect of the midfoot, and that's the head of the talus. So why do you see the head of the talus in a flat-footed individual? Well, it's because the subtalar joint that includes the navicular everts. And in eversion in the flat foot, the navicular goes from aligned with the head of the talus to outwards and upwards. It rotates away from the head of the talus. So the head of the talus is exposed because the subtalar joint has everted. And that's why, so in people with flat feet who are standing, you see a bony prominence in that general region. It's the head of the talus. You can, but in someone with an accessory navicular, an enlarged navicular, there's that prominence is plantar medial, and it's very close in location to what would be the head of the talus. Well, how can you tell the difference? Well, you tell the difference by putting your finger on the bony prominence. And then with your other hand, invert and evert the subtalar joint. If the bump stays with your finger as you're inverting and everting, it means that it's the navicular because it's moving. If your finger is on the bump and when you invert and evert, the bump seems to go away, that you don't see it, but as you're inverting and everting, your finger is not moving with the bump. It means it's the head of the talus. Okay, so the diagnosis, so to know right away is you put your finger from the side, take an arrow and put it right on the bump.
Okay, so that's about the differentiating the head of the talus and the prominent navicular, right? So basically, but there is no other differential diagnosis in this case. It's either the head of the talus or the navicular.
Right,
Yeah.
exactly.
Exactly.
Yeah.
Okay, the next question, which I could not find answer, and I thought that let me ask you that why in some children it's become prominent and not in others? What is the reason for that? We know that there is always some anatomical variation, but what is the reason for this condition?
It's just an anatomic variation. You know, people are short, people are tall, people
Right.
have big ears, small noses. I mean, it's just an anatomic variation. There are, and so this is an accessory ossicle. There are dozens of accessory ossicles in the foot, dozens of them. There's a great book written by Kohler, Kohler, which is called The Anatomics. Let me see. It's a book that it's really, really thick, and it shows X-rays, examples of X-rays of all the anatomic variations in the foot, in fact, of the whole body. But in the foot, the number of anatomic variants is enormous. And one of them includes accessory naviculars almost every place.
So basically, like we don't or we can't answer the parents' question that why it's like that. Is there any genetic or hereditary role in that?
There's some evidence suggesting that accessory naviculars are inherited. It's not strong evidence, but there's some suggestive evidence that there is.
Then coming to the practical issues, the few complaints are very common. The first is pain. On examination, there is a tenderness. Some people have a callosity, and some have pain because the medial border of the foot is, the shoe wear is touching the prominence. And sometimes it's associated with flat foot. So what is the importance of that flat foot with this? Or both are independent thing and they are just coincident in that patient?
So Kohler, the same person who wrote that book, believed that accessory naviculars were always associated with flat foot, and that if you're going to treat the symptomatic accessory navicular, you also need to treat the flat foot. Through decades of research, that has been disproven. Perhaps 20% of people have flat feet. About 12% of people have accessory naviculars. So if you just look at it statistically, 1 out of 8 and 1 out of 20, when you put those two statistics together, I mean, there are going to be a lot of people who have both. But as far as cause and effect, there's no research scientific evidence that one causes the other. It's just coincidence. Again, 1 in 20, 1 out of 5 people has flat foot, and 1 out of 8 has accessory navicular. So of course, there are going to be a lot of people who have both.
Okay, so 1 out of 60 is, I think 20 multiplied by 8. So 1 in 160 will have both.
Yes.
Yes. Okay, right. So basically, the diagnosis is very clear on clinical ground. Do we need to go for X-rays?
Yes. I think it's appropriate to do so, again, to help. A lot of this is education, and so I think that X-rays, not advanced imaging. So many people in the U.S. these days, especially orthopedic surgeons in private practice who own their own MRI machines, they're not getting X-rays anymore. They're going right to MRI. And it's ridiculous. So you get standing x-rays of the feet, and then you can better describe to the family, and these are often teenagers, explain to them too what they're seeing so you could talk about management. So you have x-rays.
Yeah, but like why standing X-ray? That's the question. Now, why not a non-weight bearing X-ray, and why you are looking for a weight bearing X-ray?
So weight bearing, so these are malformations, they're anatomic variations, but they're associated in almost all cases with deformity. So I already said that the malformation, the accessory navicular, doesn't cause the deformity, but they're often there together. And um, the symptoms are managing often non-operatively the deformity as well, managing the deformity. How do we relieve the pressure in that area? So whenever you're evaluating foot deformities in children or even malformations, weight bearing gives you a frame of reference from which you can go. You can always get non-weight bearing films, other reviews if you need them, but you want to get weight bearing films so you see the condition and also how it's represented in the physiologic position, which is weight bearing. The thing about these, when you get these x-rays, so the standard set of x-rays when you're evaluating a child's foot deformity is standing, AP, lateral, and oblique. Now, the oblique film is not going to show this. In fact, the standard oblique x-ray is going to make it even impossible to see the navicular. This is one case where you have to order standing, AP, lateral, and both oblique views, because the standard oblique view is shot straight down in the sinus tarsi, and what you need is straight down from the other side of the foot, from the medial side of the foot. It's called the lateral oblique, but it's shot from the medial side. And it's the non-standard oblique that puts the accessory navicular in a true profile so you can see what you're looking for. Whereas the standard medial oblique, you can't even see the navicular. It's just not visible.
So let's have a X-ray. So this is a non-weight bearing X-ray.
And what you can see is if you look at the tail of it, and that's
okay, sorry. Yeah, okay, yeah, please, yeah.
So that's not weight bearing, and we know that because when I saw the weight bearing X-rays, I saw that here the navicular is in front of the talus, and on both sides you can see an enlargement of the navicular on the medial side of both bones, and you can see a little center of ossification. The accessory navicular is not just the ossicle, but in all individuals who have accessory naviculars, there's the accessory ossicle, that little P-shaped ossification, but the main body of the navicular is also enlarged medially. So it's not just the ossicle, the whole medial aspect of the navicular is large. In these x-rays, maybe when I annotate it, it'll show better. So these are non-weight bearing. Now go to the next slide. These are weight bearing. And when you see the annotated ones, for those who are not as familiar, the trainees, so there's the lateral. So here, now these are the non-weight bearing films, and I drew in the axis of the talus and the first metatarsal, and they're fairly parallel, not exactly. The yellow dots I placed on the most prominent part of the navicular, and the orange dots are on the most prominent part of the medial head of the talus. Now look how close the orange and yellow dots are, and look how almost parallel the talus and first metatarsal are. If in these feet you've palpated over the yellow dots, you're touching the head of the talus. I'm sorry, you're touching the navicular. Next slide. These are the weight-bearing ones. Look how far away the yellow dots are from the orange dots. And that's because in weight bearing, the subtalar joints everted, and as they everted, the navicular and the rest of the bones of the CPU moved away from the talus. And look at the angles between the talus and the first metatarsal. These represent flat foot deformities. Those lines are no longer parallel with each other or near parallel. There's eversion. These are flat feet, and just as I said, if you have your finger where the yellow dot is, In eversion, that's where the finger's going to be. And then if you go back a slide, now these are inverted, and the bump moved and became closer to the head of the talus. Next slide again. They everted, they moved out. So this confirms what happens when you put your finger on there clinically and you invert and evert. You also see the value of the weight-bearing films, that this is truly what the feet look like in weight-bearing. And this is when the child's symptomatic. They're not symptomatic when they're sitting. They're symptomatic when they're standing, walking, running, and playing. I also drew the black dotted lines on there. That is the normal size of a navicular. That the medial edge of the navicular is almost collinear with the medial side of the medial cuneiform. So yes, there's an ossicle, and yes, there's a synchondrosis of the ossicle with the main body, but the whole medial, plantar medial aspect of the navicular is large. Think now, if it was symptomatic and you took out just the ossicle, it'd still be a bump there. If the pain were due to inflammation in the synchondrosis, in that cartilage layer, which there often is, that would go away, but there's still this big bony bump. So you can't just remove the ossicle and say you're done for the day. You have to actually remove the enlarged part of the bone. I think that's the last part here. So I don't know if you want me to go on, or do you have some more questions at this point?
Yes, yeah. So now, like we have a X-rays. There are three type of like the accessory navicular described. Do they have any relation with the prognosis?
So type 1 is a spherical ossicle. It looks like a pea, like a green pea, that's in the very last centimeter of the tib post before the tib post inserts and engulfs the navicular and the rest of the bones. That pea it's almost like a patella within, so the type 1 within the tib post is like a patella in the quad expansion. And it just generally doesn't have an issue in the foot. A type 2 accessory navicular is this. So here you have one large bone that has two centers of ossification, the large one, and then right at its plantar medial tip, where the tib post is inserting, that part of the cartilaginous bone has started with a secondary ossification center that has a synchondrosis to the main body that in time, maybe in another few years, will ossify. And you will not see the synchondrosis anymore. You'll not see that black line. It will just be one large accessory navicular. A type 3 accessory navicular is that final product that most likely started like this, and then over the next few years, and usually before age 20, has become one large, solid, single ossification center. So why do accessory naviculars hurt in some people? Well, 12% have pain. That means 1 out of 8 people. If they all cause problems, adult foot and ankle surgeons would have no time to do anything else other than treat accessory naviculars. Really, if 1 out of 8, the population of India is 1.4, 1.5 billion. What's 1/8 of that? I mean, just think of if accessory navicular is a problem, no foot surgeons would have time to do anything else other than operate on accessory naviculars. And that's not the case. So only some are symptomatic. They could be symptomatic for 2 reasons. One is it's a big bony bump that pushes the skin into the ground or into the shoe. And that, if adults with accessory navicular have pain, that's the pathology. Bony bump, soft, tender skin, shoe or ground, and the sandwich can cause pain. In teenagers who still have a synchondrosis, they can develop pain for another reason, which is the inflammation within the synchondrosis. So we were talking first about the inflammation in the apophysis of Sever's. Well, this is, again, it's an inflammation within that cartilage synchondrosis. Tib post is pulling, the foot is everting, pulling back, tib post, foot, And this back and forth can cause repetitive stress, trauma with microfractures in the synchondrosis that's painful. So teenagers who still have this pathology can have pain from the inflammation in the growth plate and or pain from the bump. Adults could only potentially have pain from the bump. And so in young people, so in nobody can the bump get smaller. You can modify shoe wear, so put a shoe lift in, wear different types of shoes so that the bump isn't squeezing the skin so much against the shoe. But in kids, you can also try to stop the inflammation by temporarily cutting back on activities like you do for Severs. By putting an over-the-counter arch support in, that will elevate the arch. It will take a little stress off the tib post. And if you give non-steroidal anti-inflammatories as well, non-operatively, you can try to stop the inflammation in the synchondrosis. How often does that work? How effective is it? It's hard to study, but it makes sense biomechanically, and it keeps people out of the operating room in some cases. So you try non-operatively to stop the inflammation in that area. Modify shoes, modify activities, over-the-counter inexpensive arch support to take some of the stress off the tib post to stop the inflammation. And if that doesn't work, then you have to move on to the next step, which is surgery. But that's one of the two reasons that teenagers have pain. It's pain in the synchondrosis.
Okay, just before we move on to the surgery, when do we need to go for surgery? When parents or the family is tired, or like, is there any other indication?
So in every condition, that's why my opening statement was that we're not just surgeons, we're physicians and surgeons. And I was always so proud of the fact that I was a diagnostician and that I could treat conditions to help children both non-operatively and operatively. The only bullet, I just didn't have a gun. I had tools that I could use, and one of them is to try to stop the pain non-operatively. So again, it's impossible to study. I don't know any studies that say how effective non-operative treatment is, but you can never unoperate on anybody. So you start non-operatively, and if it doesn't work, you go to surgery. You can't operate and say, let me try to not operate. You already operated. You're done. So I would say try those modalities, and if they don't work, then do the surgery. The surgery is successful if it's done properly. And I believe that the technique that I described should work 100% of the time without complications. But when you read about surgery for accessory naviculars and the kind of crazy things people are doing, the complication rate is unacceptably high. It's unacceptably high for a condition that is probably not even symptomatic in most people. So if you're going to go to surgery, and if you like doing surgery for these, you better first have tried non-surgery because you want to avoid the high complication rate of surgery. And it's high. The surgery then is to, if it's a synchondrosis, you want to remove the synchondrosis because it's inflamed. But you also, as I said earlier, you need to remove the enlarged part of the navicular, because if the size of the bump is not necessarily the problem in the 13-year-old, it may be the problem in the 33-year-old when that 13-year-old becomes 33, and all you did was remove the ossicle. So you're already there. It doesn't take much more time or effort to remove the ossicle, the synchondrosis, and the enlarged part of the navicular. And that can be done through a tendon splitting approach, as I've described and written about. It doesn't separate the tib post from the navicular. It merely, in the line of the fibers, opens it up, exposes the enlarged part of the bone without detaching the tib post from the navicular. And then with an osteotome, you could take off the enlarged part that includes the ossicle, or first take the ossicle and then use your osteotome to take off the enlarged part, and then imbricate the tendon. We've not detached it at any point. All we did was we took out the space-occupying lesion within the middle of the tendon, and now there's a big cavity that you imbricate the tendon, and you have a nice tube again that's effectively the same length, because there's no reason to advance it. What some doctors do is they remove the tib post from the bone. Then they remove whatever they're going to remove, and then they try to reattach it with suture anchors or drill holes. And the complications of the suture anchors are, I mean, it's almost laughable. I've seen so many kids over the years who had problems because they had pain and inflammation from the suture anchors. And I was trying to dig out the suture anchors or dig out these in like type 2 or two size permanent sutures that made a big bump on their own. So the treatment could be worse than the condition. Kohler thought that when you remove an accessory navicular, you should advance the tib post because that would create an arch in the foot that was already flat. Well, we know so well that soft tissue work does not change the shape of a flat foot. Only bone surgery changes flat feet, the calcaneal lengthening osteotomy. So the idea of advancing the tib post to create an arch in a flat foot when you're removing accessory navicular doesn't make any biomechanical sense, and studies have confirmed that that's not the case. So don't detach it. Don't detach it and then run into complications of the suture anchors. What some other people do is they try to just excise the synchondrosis. They leave that tiny little sliver of bone, take out the synchondrosis, and then think that they can fuse the little sliver of bone to the rest of the bone. It dies. It doesn't work. So again, the technique I described works all the time. No detachment, no advancement, and take out the enlarged part of the bone and then suture it up. So,
Okay. Yeah, sorry. We are coming to the end. So just two quick questions. The first is how much bone we need to remove? That's the first question. Do we need to like draw a line parallel to medial cuneiform or a talus, and we need to decide on table that we have removed adequately? That's the first question. And second, very small number have associated flat foot. And if they want improvement in the shape, can we combine this procedure with the Mosca's procedure?
okay, so if you look at skeletons and if you look at books, the medial and plantar medial aspect of the navicular is pretty much co-linear in the same line as the medial cuneiform. So when I've operated on these, I use mini fluoroscopy, so it's low dose radiation for the child and for me and the team. And I line the osteotome up with the edge. So it's not just medial, it's plantar medial. So you go to the plantar medial of the navicular and you put your osteotome from distal to proximal, plantar medial, slightly oblique, and you chip it off and you cut off the enlarged part so that it's essentially flush with the medial and plantar aspects of the medial cuneiform. So it's just a rough assessment. There's a lot of variability in what normal is, but that's what I do is I use the medial cuneiform as my target of the edge. And then as far as association of the two conditions, like I said, it's not cause and effect, but there are a number of kids who have very flat feet with their accessory naviculars. And they usually also have tight tendo Achilles. So the options are remove the accessory navicular and tighten the heel contracture because perhaps some of the pain is not just the accessory navicular, but that tight tendo Achilles that's pulling on the synchondrosis. So you want to lengthen it. I have also done concurrent deformity correction with the calcaneal lengthening osteotomy. I don't have any strict criteria for which is which. But one thing that has sort of encouraged me to do deformity correction is, as I said, you palpate the accessory navicular. In very flat feet, there's another bump. It's the head of the talus. So you palpate the head of the talus, you palpate the accessory navicular. They're both tender. And you know that once you remove the accessory navicular, then the already tender head of the talus is going to be even more prominent because it's not sharing weight bearing with the navicular anymore. So in those cases, I've said to the family, I'm sorry, I don't have any scientific articles that I can share with you to say that this is the right thing to do, but I would recommend also doing deformity correction. And I tried to explain it biomechanically. They're usually more than willing to accept it because all they know is they hate the shape of the foot. They hate the pain, but they hate the shape of the foot. It's actually harder to convince those who have only mild flat foot deformities, not to correct the flat foot deformity at the same time.
Okay. So thank you very much for like explaining the diagnosis and the treatment and the evaluation very completely. And probably when we read books, we don't get that much insight by reading the books. So thank you very much for sharing your vast experience and your analytical skill with us. And I'm sure that the young pediatric orthopedic surgeon are also going to get benefit out of this. I'm very happy that we have at least 10 consultants today attending your session. So that's really something encouraging to all of us. Thank you once again
Right.
for coming to the platform.
Thank you.
Thank you.
Thank
Bye.
you.
Yeah.
Thank you. Bye.